Hi, my name's James Rippey and I'm going to discuss the emergency department surgical airway pathway. To get onto this pathway, you have to have gone through the difficult intubation pathway. You've had a patient who needs intubation in the emergency department. You've prepared them as best you can. You've tried to intubate them, but been unsuccessful. You've then tried to bag valve mask ventilate them, but can't do that either. You tried to put down a laryngeal mask, but that's not working. There's no time to waste. Now, you have to go on and do a surgical airway. And that's how you enter this pathway. You're in the can't intubate, can't ventilate situation. Some people call it the can't intubate, can't oxygenate. Before we go through this algorithm, you need to decide which limb you're going to choose. Are you a Seldinger technique sort of person or a surgical technique sort of person? If you're a surgical type, you're probably going to choose the scalpel bougie ETT technique. That's where you make a hole in the neck using a scalpel, you put a bougie into the trachea through that, you can ventilate through the bougie after attaching the little adapter. Once you've oxygenated the patient, then you can railroad a size 6 cuffed endotracheal tube over the top, and that works really, really well. To do it, it helps if you're familiar with surgical techniques and that you've practiced it. The problem with this technique is people who haven't done surgical training are often reticent to start it and would rather not do a surgical airway. The great advantage to it is that it's actually quicker to get a definitive secured airway than the Seldinger technique. Bleeding is also a risk. So basically, if you're happy with surgical techniques, this is probably the technique you're going to choose. And there are some great educational videos on how to do that by Andy Hurd. The alternate is the cannula cricothyroidotomy technique. In this one, you put a cannula into the cricothyroid membrane. You can oxygenate through that, either using the manujet or oxygen tubing from the wall with a little Y connector into your cannula. The patient can be reoxygenated through that. Now, occasionally, that buys you enough time. You reoxygenate the patient. You can think about, can you wake them up, or can you get other upper airway techniques? But more often than not, you'll need to then go on using the Seldinger technique. Put a wire through that cannula and then dilate and feed the Melker 5 cuffed Seldinger technique ETT into their trachea to get a final secure airway. The advantage of this technique is that many of us are really familiar with Seldinger techniques. We're used to doing that, and even though it's a bit more fiddly, it's going to be safer in our hands and we're more willing to do it. The other advantage is you may buy time because you reoxygenate through a cannula. Someone might be able to get a definitive airway through the top end. Disadvantage is it's actually a little bit longer to get a definitive airway than the scalpel bougie technique. Another final advantage is if it doesn't work, you can then move to a scalpel bougie technique anyway. Only important thing from my point of view is you have to decide now which one of these you're going to do. Are you going to be a cannula Seldinger technique sort of person or a scalpel bougie person? Let's go back to the algorithm. You've realized you have to get a surgical airway. First question, is the airway anatomy palpable? If so, choose which technique you're going to use. You're going to either use a scalpel bougie, you get the bougie in, you can ventilate through that and you railroad your size 6 cuffed ETT tube. Or you're going to put your cannula in, you can oxygenate through that. If the patient does really well on that, you might be able to wake them up or use another upper airway technique, or you might convert to a definitive airway using the Seldinger technique and the Melker 5 cuffed ETT set. Going back to the top, what if you can't feel the airway anatomy? So you can't. You've got to find the trachea. You don't know where it is though. You can do this open with using a scalpel and fingers, where you make a longitudinal incision in the midline anterior neck about 6 centimeters. You open up, you feel with your fingers and dissect down till you feel the trachea. Once you do that, you can then choose which technique you use, having secured or found the trachea. So that's the open technique. Alternatively, you can use the cannula. You put it in where you think the trachea is going to be, and if that doesn't work, you move one side a little way and try there, move the other side a little way and try there, and keep doing that. until you get a nice oxygen air coming back into your saline filled syringe. Again, there are some really good videos on how to do this on Andy Hurd's YouTube videos. The alternative to finding the airway, if you're an expert with ultrasound and you have a machine that's immediately available, there have been some studies that show that ultrasound guided cannulation of the trachea can be done rapidly and accurately. But to do that, you have to be well practiced and expert and have ultrasound immediately available. So going through it again, airway anatomy not palpable, an open technique where you use a scalpel and then your fingers to find the trachea, or a closed technique where you put the cannula in trying to find that trachea, either blind or ultrasound guided if you've got the expertise. Once you find that trachea, you then, if you've gone the cannula way, are going to go the cannula cricothyroidotomy. If you've gone the open way, you then can choose which one you're going to do. And that's the end of this pathway. Relatively simple. Make a decision which one you're going to do and go for it.